Good evening, everybody, for giving me this wonderful opportunity. It has been quite a while since I interacted academically with undergraduate students. I am a DM hepatologist. I will try to speak as briefly and as crisply as possible without burdening with too much information. The slides that I made today were borne in mind that this was primarily for the final year MBBS students who don't need to know everything of everything, but they need to know the basics of the subject of discussion today, for our topic being cirrhosis of liver. First, let us look into what is cirrhosis of liver. There are two main aspects in this definition. First aspect is there are some structural changes in the liver in the form of fibrosis, in the form of liver architectural damage. Along with it, the liver's normal function also gets hampered. So there are two definite, very clear reasons in the, for which this cirrhosis was defined as a diffuse process characterized by fibrosis in liver and where normal liver parenchyma architecture gets changed into structurally abnormal nodules. These two aspects go ahead and produce two different things. The first thing that we have is something known as portal hypertension. Portal hypertension is something like the normal when we have portal venous blood coming in from our gut, draining through the liver and going into our heart through the hepatic veins and the inferior vena cava. The resistance within this structurally abnormal liver or cirrhotic liver is very high. What happens? It acts as a bottleneck to the flow of blood from the portal vein to the heart. What happens? This amount of blood gets congested. When a lot of blood gets congested, the pressure in that same area rises. This is what is known as portal hypertension. What happens due to portal hypertension? The amount of blood in this circulation, in this portal aspect, tries to find other pathways to reach its final destination, in this case, the right atrium. So what happens? A lot of channels, blood vessels, which were normally of caliber in the range of nanometers or a few millimeters, become in the caliber of few centimeters. What are these called? Varices. We will speak with it about it later. So these two changes, structural and functional, lead to one, portal hypertension. I already explained the meaning of the word portal hypertension. And the second part is it leads to loss of liver parenchyma. What is the meaning? In every organ, there are some principal cells and there are some support structures. In case of liver, the principal cells are the hepatocytes. Those are the functionally active workers in the liver mass. And there are other support stuff also. In case of cirrhosis, a lot of these hepatocytes get damaged. So what these hepatocytes do, they play a major role in our bilirubin metabolism. They synthesize albumin. They they synthesize several clotting factors. They help handle several body metabolites. Principal of them, something which we'll be hearing a lot about in this talk, ammonia. Several drugs are also metabolized in the liver. There is hardly any drug which is never metabolized in the liver. And this leads to something known as liver parenchyma loss. So these two aspects, the structural change and the functional change, lead to two problems, portal hypertension and loss of liver parenchyma. What this leads to? This leads to advancement of cirrhosis and all its clinical problems and its clinical manifestations for which we know it. Moving ahead, how does a patient get diagnosed with cirrhosis? We know that liver parenchyma gets lost. We know that the liver shape gets distorted. But can we go in and have a look at the liver for each and every patient? Just doing a diagnostic laparotomy to diagnose cirrhosis is not possible. Therefore, how do we diagnose cirrhosis in real life? We diagnose it when portal hypertension is present. How? When ascites or varices are present. Ascites being detected either by ultrasonography or by other cross-sectional imaging modalities, along with portal hypertension such as dilated portal vein, esophageal varices, or gastric varices. These are the most common varices to be present and diagnosed on upper GI endoscopy. Along with it, say the ultrasonography of the abdomen also shows a shrunken liver, a coarse liver parenchyma, irregular liver margins, dilated portal vein, and collaterals. Most of these get detected in very advanced cases. All of these might not be present concomitantly, that is together, in a given patient at a given moment, especially if the liver is having cirrhosis, but the cirrhosis is in early stages, so to speak, compensated cirrhosis. What is compensated? What is decompensated? We will talk about this later on in this presentation. Moving ahead, how common is it worldwide? This is an abstract. You don't need to remember the meaning of word abstracts as yet. Just go through what is written. Approximately 2 million deaths per year worldwide occur due to liver disease. Among them, approximately 1 million deaths occur due to complications of cirrhosis and 1 million due to viral hepatitis and hepatocellular carcinoma. Hepatocellular carcinoma is another complication of cirrhosis, and viral hepatitis, as we will see, sometimes are the cause of cirrhosis. In 2019, if all causes of death were ranked worldwide, then cirrhosis came in number 11 place and liver cancer, primary liver cancer, came at number 16 place worldwide. And taken together, about 4% people worldwide who die from cirrhosis of liver or its problems. What does it also lead to? Loss of ability to work, which we know as morbidity. So in addition to mortality, it also leads to morbidity. Let's skip the rest of it, because right now the point is cirrhosis is not an uncommon disease. This slide suffices to prove that. Next, how common is cirrhosis in India? This 2017 study shows a map of India to the left, and to the right are data or flowchart, so to speak, of this study. What happened was, all patients who attended 11 centers, which are marked in the map of India to the left, which covers northern India, eastern India, northeast India, central, western India, and south India. So to speak, it's a pan-Indian study. 11 centers agreed. They looked at a lot of patients. And among those lots of patients, the total number of patients with whom liver disease was found was 20,000. Among these 20,000 patients, people of other nationalities were excluded. People who had been diagnosed with cirrhosis earlier or had HCC, which was very advanced to begin with, were excluded. This left with new onset of cirrhosis of liver in 13,000 patients. That's approximately 1,000 patients per center. And the data from this was analyzed, and among these 13,000 patients with liver related problems, about 4,500 people had cirrhosis, meaning that at any given point of time, if liver related problems are diagnosed from academic settings, so to speak, medical colleges, 1 out of every 3 patients with liver related problems is potentially a cirrhotic patient. And also among these Among these 13,000 odd patients, about 450 had liver cancer to begin with, meaning about 2% to 4% people with cirrhosis have a lifelong risk of development of hepatocellular carcinoma. But we need to look out for all patients. Otherwise, patients with cirrhosis and hepatocellular carcinoma will only get detected in very advanced stages and not in early stages where there are more treatment options. Moving ahead, what are the common causes of cirrhosis? Alcohol is very high in India, about 17%, not as high as the figures in the Western population, that is to say in United States or in America, from which most of our textbooks get written. Viral hepatitis is pretty common in India. Hepatitis B virus related cirrhosis is still the most common cause of cirrhosis in India because there are lots and lots of hepatitis B virus affected patients in our country. Hepatitis C is also not uncommon at all. NAFLD stands for non-alcoholic fatty liver disease patients. This accounts for approximately 13% of all cirrhotic patients that we find. In whom do we suspect NAFLD? A person who was obese, a person who had diabetes, a person who had other risk factors of metabolic syndrome such as dyslipidemia, a person who might have had obstructive sleep apnea and was subsequently detected with cirrhosis of liver. In these populations, we suspect that this is related to non-alcoholic fatty liver disease. And causes other than alcohol, hepatitis B, hepatitis C, and non-alcoholic fatty liver disease accounted for about 1 in 6 patients with cirrhosis. Why? Because we often come across a term which is cryptogenic cirrhosis. If we look at the table in blue to the right of this slide, several other causes of cirrhosis are also mentioned. These are not all the causes of cirrhosis which exist in this earth. There are lots and lots and lots more. But what is covered to the left of this slide are the most common causes of cirrhosis in India, and the ratios will differ, but they are still among the most common causes of cirrhosis worldwide. What is covered to the right, such as primary biliary cirrhosis, primary sclerosing cholangitis, autoimmune hepatitis, cardiac cirrhosis, Wilson's disease, cystic fibrosis, these are very rare causes. These are good to read causes. You might come across a few patients in your lifetime, but these are not some people you see on a regular basis. So these patients, and if somebody can test for each and every cause of cirrhosis possible, still there will be about 20% odd patients in whom the cause for cirrhosis will not be very clear. This population we label as cryptogenic cirrhosis. Not that they don't have cirrhosis, it's just that why they had cirrhosis is not very clear by the investigations. Moving ahead, a very important question, a very pertinent question: how do we stage cirrhosis? We go back to the definition of cirrhosis. There are two problems: structural changes and functional changes, and which lead to two effects: portal hypertension and liver functional mass reduction, otherwise known as hepatocellular parenchymal loss. What it leads to: ascites, metabolites handled by the liver affecting the brain, also known as hepatic encephalopathy, bilirubin rising, albumin falling, and synthetic function of the liver being otherwise assessed. A cheaper way to actually do that is testing for INR, or international normalized ratio, which can also be done with P time and prothrombin index. Here, these 5 parameters are scored from 1 up to 3 depending on their grades. Say A person is not found to have ascites, has cirrhosis, but no ascites on USG or other imaging. So for the parameter of ascites, the person gets a score of 1. The same person had a very low grade of hepatic encephalopathy. If we look at the chart, he or she gets a score of 2. The total bilirubin, say, is 1.5. Since it is less than 2, here the person gets a score of 1. Albumin being, say, 2.9. As per this chart, the person gets a score of 2. And INR being less than 1.7. Again, the person gets a score of 1. So it is 1 plus 2 plus 1 plus 2 plus 1 equal to 7. That's how we score cirrhosis by the CTP or Child-Turgot-Cook score. The lowest possible score is 5. The highest possible score is 15. The lower the score, the better the ability of the liver to work, even though it has cirrhosis. The higher the score, the worse is the ability of the liver and the less likelihood of the patient living through for longer durations of time. So it is staged in 3 classes: class A, class B, and class C, which cover CTP scores of 5 to 6, 7 to 9, and 10 onwards, respectively. There is another way we can score cirrhosis. This is the MELD sodium score. This is complicated because it is logarithmic. We don't need to remember the equation. We don't need to, just memorize the equation. There are computers and mobile apps to help us do it. What we need to remember is it looks at a patient's serum creatinine, serum bilirubin values, and INR levels. The higher these levels, the score goes higher. And we need to remember a magic figure of 15. Why? If a patient has got a MELD sodium score more than or equal to 15, then the person is thought to have become a candidate for consideration of liver transplant. Why is MELD score important? There are other scores to do it also. MELD score MELD sodium score also incorporates sodium, which I didn't give here. This is the MELD score, which I mistakenly wrote. The MELD score predicts mortality. That means higher the score, lesser the chance of patient surviving for longer durations of time. If the MELD score, say, is more than 20, then in 3 months, at least 20% people will no longer be with us. If the MELD score is more than 30, then in 3 months, at least 50% patients are not going to be with us. That is something which is definitely food for thought. My apologies for not writing the sodium part of the equation. What I wrote, in fact, was the MELD score. There is another part of it which incorporates the serum sodium levels, making it the MELD sodium score. Moving on, we spoke about compensated cirrhosis. We spoke about decompensated cirrhosis earlier in the talk, and I promised that I will explain what compensated is and what decompensated is. Score wise and parameter wise, if we look at the Child-Turgot-Cook score or Child-Cook-Turgot score or CPT score or child score, whatever name we call it by, all names are valid and well accepted internationally. If we have a class A cirrhosis, it is considered as a compensated cirrhosis. That is, if the child score is less than 7 up to 6, that means 5 or 6. This is considered a compensated cirrhosis. If it is more than 7 or equal to 7, it is considered as a decompensated cirrhosis. But if we look at the patient clinically, any one of these things being present makes cirrhosis decompensated cirrhosis. What are those 4 things that we need to remember? Ascites, free fluid in the peritoneal cavity, GI bleeding, hematemesis, and melena, which are the commonly occurring things. Hepatic encephalopathy, in which the most common cause is definitely ammonia, but as we grow higher in our academics, we will learn to know that there are many other things also. And coagulopathy, meaning INR getting deranged, abnormal chances of having bleeding from anywhere in the body. We also know about some condition known as DIC, disseminated intravascular coagulation. Cirrhosis is the bleeding tendency in cirrhosis is not as simple as it sounds. I have made a very simplified portion of it. In cirrhosis, the portion of the blood coagulation cascade which helps clot blood gets hampered. In addition, the portion of the coagulation cascade which prevents blood from getting clot also gets hampered. Overall, in most situations, in decompensated cirrhosis, the bleeding tendency is higher than the clotting tendency. Thereby, the term is coagulopathy and not anything else. This is a picture of what we typically look at. I spoke about things which are known as varices. What are varices? When when blood from the portal system comes to the systemic circulation through pathways through which they usually don't come in very high volumes. These exist all over in our body. On the right hand side, the two images that we have are images from upper GI endoscopy in the esophagus of patients near the lower end of the esophagus, just distal to which, crossing which, we will get into the stomach. If we look at the image on the right bottom, that is how a normal esophagus looks. If we look at the image on the right top, the things which are bulging out with some red signs on them, those are varices. There are other ways a varices looks also, but that's how esophageal varices look. These abnormal pathways or varices commonly occur near the gastroesophageal junction in the distal esophagus mostly. Also, they occur in the stomach only, in which case they are known as gastric varices. Sometimes they occur in the rest of the gastrointestinal tract, such as the small intestines, in which they are known as ectopic varices. Some varices also occur in the proximal and mid portions of the rectum, in which they are known as rectal varices. Some varices occur on the abdominal wall outside, which are known as caput medusae. Some varices might occur on the abdominal wall on the peritoneal surface. They are known as ectopic varices as well. Some varices may occur in the retroperitoneum, very near the IVCs. All these are known to occur, and other sites of varices are also known. Not that everything can be present in the same patient, but everything which can occur between connecting the portal circulation to the systemic circulation at any given place might occur. But the common sites still remain, the commonest being gastroesophageal junction, also known as gastric varices, inside the stomach only, which are known as esophageal varices near the GE junction, in the stomach only, which are known as gastric varices, and rectal varices. These are still the common sites of varices which are found. Moving ahead. Here in this very small slide, I will speak about the principles of treatment of cirrhosis. One, if we have a cause of cirrhosis which is treatable, we need to treat the cause. What do we mean? Say a gentleman drinks a lot of alcohol. We need to make him stop drinking alcohol. This will not lead to his cirrhosis getting cured, but this will slow the rate of progression of cirrhosis from compensated to more decompensated parts significantly. Say a person has got hepatitis B virus, which is circulating in his body, and that has led to his cirrhosis. We need to treat for the virus with the help of antiviral agents. Say a person has got circulating hepatitis C virus RNAs. We need to treat for that virus. Say a rare disease known as autoimmune hepatitis has occurred. Then the person might need medicines which are immunosuppressants or immunomodulators. I am speaking about something such as steroids and some other medicines, so to speak. The second principle of treatment of cirrhosis is looking at the nutrition. People with decompensated cirrhosis especially, their muscle mass gets reduced, their muscle strength gets reduced, also a lot of fluid accumulates in their body, and cirrhotic ascites with hyponatremia, if we look at it from the sodium point of view, it is also something which is known as hypervolemic hyponatremia. So when we take care of this excessive volume, we are often left with a frail body when most of the water is uh, taken out from the body with the help of medicines. So we need to take care of nutrition. How? We need to take care of the calories which the patient consumes per day. We need to take care of protein intake, irrespective of the stage. 1 gram per kg per day to 1.2 gram per kg per day, even in presence of hepatic encephalopathy, must be given. We need to ensure that if the patient has or had ascites, fluid restrictions are in place. Typically, it is about 1.5 liters in a 24-hour period. We need to look at salt restriction measures as well. This is up to 2 grams of salt in a day, and 2 grams of sodium in a day can be consumed, which translates to 5 grams of table salt in a day in any form can be consumed. Moving ahead, management of complications. What are the complications of cirrhosis? Ascites, GI bleeding, hepatic encephalopathy, and coagulopathy. I will speak on them one by one. Say a person has got ascites. The principles of management of ascites are dietary salt restriction, dietary water intake restriction. The second principle will be giving them diuretics. Usually spironolactone and furosemide combinations are used. If a person does not respond, or if a person develops side effects to diuretics, such as changes in AKIs, changes in electrolytes, and other things, then we cannot increase the dose of diuretics any further. We might need to stop them temporarily. In this situation, or if a patient develops tense ascites, the abdominal fluid needs to be drained. This is known as abdominal paracentesis or abdominocentesis. This can be done. There are other medicines also, but these are the most common ways we deal with it. Second being GI bleed. In GI bleed, a person with cirrhosis mostly bleeds from rupture of these gastroesophageal or gastric varices. So the patient needs to be resuscitated. Airway bleeding circulation needs to be looked into. Blood transfusion might be needed to maintain hemoglobin if the hemoglobin falls. We might need to give them pressure agents to maintain their blood pressures, and we need to give them some medicines to reduce the bleed. These are known as pressors, such as terlipressin, octreotide, things like that. In addition, the person should receive antibiotics, and after the patient is adequately resuscitated, upper gastrointestinal endoscopy is done, and if varices are found to be ruptured, some treatment is given with the help of endoscopy, such as binding those varices in layman's terms, or endoscopic variceal ligation. How it works is beyond the scope of this talk, but it works. Then, to prevent bleeding, we need to give certain medicines to reduce the chance of bleeding again, such as propranolol, carfentanil, things like that. What if the patient has developed hepatic encephalopathy? We need to give antibiotics, we need to give medicines to help the patient pass a lot of stool to reduce the gut bacteria from producing a lot of ammonia. And also because every cell in our body does not live infinitely. There is a lot of cell inside our gastrointestinal tract which gets shed inside the gastrointestinal tract lumen, and we lose it with stool every day without even noticing. if this cells, the amount of nucleic acid from these cells is collected, that's not going to be a very small amount. If this accumulate in a patient with cirrhosis, we are looking at high ammonia levels in the blood. Thereby, if we do not allow these to accumulate in the body, that we can achieve with the help of the patient passing a lot of stool, this can be reduced. Thereby, the patient needs to pass a lot of stool. Also, there are other medicines which can be given, but the principles remain the same. If a person has got coagulopathy, say a person has got gallstones, is known to have cirrhosis, needs to undergo gallbladder operation because the stones are giving him problems, and the INR is raised, we need to correct it. How? Depending on the setting, usually it is fresh frozen plasma infusion. There are other tests, more advanced tests, which are not available in a lot of centers, available to assess if we need to correct it at all. But that being aside, coagulopathy as a rule of thumb should be corrected before elective or emergency procedures if certain parameters are met. So I have covered principles of treatment of ascites, principles of treatment of hepatic encephalopathy, principles of treatment of GI bleed, and when to correct coagulopathy. Moving on to point number 4. This is monitor for hepatocellular carcinoma. Any cirrhotic patient has a 2% to 4% risk, lifetime risk of developing hepatocellular carcinoma. Typically, every 6 months, a USG whole abdomen is done to look into whether the person has got any SOL, space occupying lesion in the liver, or has developed anything which is known as a portal vein thrombosis. These are the markers which raise suspicion for hepatocellular carcinoma among others. Also, if a person's liver is affected in the form of cirrhosis, it is not only the liver which causes problems. Frequently, imagine a very obese person having a fatty liver. He is not going to die from the fatty liver. He is going to die from the excess fat in his heart, which is going to cause coronary artery disease or other vascular events at a younger age. So on and so forth. Some of these patients do die from CVA, some from sepsis, some from cardiovascular events, some from liver related events such as very advanced hepatic encephalopathy from which the patient did not recover, such as from severe episodes of GI bleeding from which the patient could not be salvaged, from something which is known as bacterial peritonitis, when the fluid inside the free fluid inside the peritoneal cavity becomes infected, in which about 1 out of 5 patients die even with the best of efforts, things like that. Or say a patient had used to drink a lot of alcohol, despite him being advised to the contrary, he is continuing drinking. This time his liver was fine to begin with, but he had a severe pancreatitis, which led to this guy succumbing to his illness. All things need to be borne in mind. When it is a cirrhosis, it is not only the cirrhosis that we should be looking towards. Thank you.
Thank you. Thanks a lot, sir. Such a nice presentation.
Hello.
And
Hello.
Hello.
Shomik,
Huh.
I think we should invite some questions from the students.
That was a very nice presentation, a perfect presentation. So I think the undergraduates, if they have any queries or questions, then they can either ask it directly or type in the chat box.
If I may, typing in the chat box will take a lot of time. Just ask directly. That will save a lot of time.
So if they are not shy, then they can directly ask the question.
Somojyoti, please continue. Shomik and Somojyoti, please continue.
Okay.
yes. So,
So we have nothing else to say. The expert has spoken. We are now waiting for the questions only.
Yes, definitely. I would request the students to come forward with any questions they have in mind. They can ask that directly.
Sir,
Yes, please.
sir, we often see that in our wards, the patient are prescribed L-ornithine L-aspartate. What is the role of that?
Well, see, if you could look over here, this is an entire volume of hepatology. So that was not scope of the talk. L-ornithine L-asparaginase has a lot of actions. One of those actions is preventing episodes of recurrent hepatic encephalopathy. The other episode is giving some metabolic support to the failing hepatocytes, so to speak. But when we look at a medicine, we look at several aspects. One aspect is number needed to treat. One aspect is number needed to harm. One aspect is cost. Now, say I give small tablets, paracetamol tablets, to every patient who has fever. 1 out of 100 patients might not respond. 1 out of 1,000 patients might have life-threatening reactions to it. I am stating arbitrary figures. I am not getting any. I do not have any reference for this. So when we give it to 100 people and 1% does not get helped, when we give 99% gets helped, so the number needed to treat is almost equal to 1. Meaning, if I give it to 1%, a 1% will get help almost. But the number needed to harm is 100, meaning 1 out of 100 people will get some harm. 1 out of 1,000, sorry, will get some harm in the form of life-threatening things. We also look at cost. When we look at LOLA or L-ornithine L-asparaginase, yes, it has some action on the liver. That's true. The number needed to treat is quite high. That's also true. Number needed to harm is very, very high. That's also true. But it is not that much cost effective. If a person is not responding to hepatic encephalopathy getting adequately controlled despite several measures, this is one of those medicines you can look into. But I strongly recommend against writing this as the or stating this as the first medicine that you will give to treat hepatic encephalopathy.
Any other questions from the students? Please, if you please, any student, any question?
Sir, one of the causes for ascites has been written in our books as planktic sequestration of blood. So why is the exact reason it is not given? So can you please explain that?
Absolutely. I will explain in very simple terms. If we are driving down a road which has got 4 lanes and suddenly the road gets narrow to 2 lanes, then there will be a traffic jam, and the cars which have gotten stuck will try to find out alternate routes for them to go out. Something similar occurs in the portal pressure system or in the splanchnic system when a person has got portal hypertension. What occurs is there is increased amount of resistance in the flow of portal blood through the hepatic sinusoids. That's why they try to find alternate routes which are known as varices or portosystemic collaterals, and the pressure they are running, meaning the amount of fluid which leaks outside those blood vessels directly or indirectly into the peritoneal cavity increases. That is why we get a lot of ascites in these patients who have portal hypertension, the cause for portal hypertension being cirrhosis. I hope I answered your question.
Thank you, sir. Totally missed the point. Thank you.
Any other questions? If no further questions from the students, then we can call it a day. A very nice presentation from Saswata sir. Thanks a lot to him for being our speaker tonight. And I would request Dr. Shoumi Goswami to actually conclude the proceedings of today. So
I just conclude by thanking Dr. Saswata once more. I wish we had such nice teachers during our undergraduate days teaching us cirrhosis of liver, but I think the students have been lucky tonight to hear in such detail from an expert like Dr. Saswata. So thank you, Dr. Saswata, once more. Good night, everyone. We'll meet for the next class as per schedule again. Thank you.
Thank you. Good night. Stay safe.